Okay, so first we're going to go over some ground rules. So for the audience, feel free to type any questions that you have in the chat. And then for the panelists, if you would like, you can respond to their questions with type responses. And it's not until there's a response to a question that will actually be published to everybody. And any questions that doesn't get answered, we will bring it up at the open Q&A at the end. And then we ask that everybody stay on mute until it's your turn to talk. And at the end, the webinar recording will be available on our NANS YouTube channel and on the NANS website within about 48 hours after the webinar. So the next slide.
So this is our diverse roster of panelists and moderators that we are excited to have with us tonight. So we'll start with having each panelist introduce themselves as we go through the slides here.
All right, good evening, everybody. My name is Daryl Latoye. I am out in Mayo Clinic, Rochester. I am an assistant professor in the Department of Anesthesiology. Did my residency in anesthesia at Mayo Clinic, Rochester. Fellowship also at Mayo Clinic, Rochester, and I've been on staff now for about 4 years or so. My practice involves a wide variety of interventions, including neuromodulation. I am also the medical director of the inpatient pain service here at Mayo Clinic, Rochester. Thank you so much for the opportunity.
Hi, everyone. My name is Paul Su. I am a openly gay pain management physician based out of San Francisco. I'm really excited for this opportunity to join this webinar today. As you can see from the slide here, all of my training is done at the University of California, San Francisco, with a background in anesthesiology. My practice kind of covers many different aspects, both kind of comprehensive pain management, which is more relevant to NANS, but also I am on the acute pain service for the hospital and also regional anesthesia, as well as kind of perioperative anesthesia care as well.
Hey guys, I'm Mirdalis Diaz Ramirez. I am assistant professor for Florida State University. This year it's been 16 years of that. I've been an interventional pain physician for over 21 years now, most of that career here in Florida. And it's the founder of the Maxillary Mastermind, which is the professional and development group for physicians who want to learn about entrepreneurship. And I'm part of the Diversity and Outreach Committee. My training, residency and fellowship, you can see, actually my residency was in Oregon Health and Sciences University. And by the time I did my fellowship, it was Oregon Health and Science University. I don't know the importance of that, but here I am and I'm happy to help. And thank you for the opportunity.
Hi, everyone. I'm Jonathan Goree. I am from the University of Arkansas for Medical Sciences. I wear a few hats. I'm an associate professor in the Department of Anesthesiology. I'm also the director of the Chronic Pain Division, the program director of our Chronic Pain Medicine Fellowship. I'm also involved in hospital administration. I'm the chief of staff elect, and I am an associate chief medical officer at the institution. Did my fellowship at Emory and did anesthesia background at Cornell. Happy to be here.
Hi all, I'm Lawrence Poirier. I'm professor of anesthesia and pain medicine at the University of California, San Francisco, where I'm the director of neuromodulation. Fellowship at UCSF, Stanford for residency, med school at Stanford, and I have served on the NANS board for about 10 years. Now currently president of the Institute of Neuromodulation and currently vice president of the International Neuromodulation Society. And I do some consulting, as you can see here, but it's not relevant to today's discussion. And founded the DOC committee at NANS.
Hi, everyone. My name is Cece. I'm one of the DI officers as part of NANS Resident Fellow Section. I'm currently finishing my last year of anesthesia residency at UTMB in Galveston, Texas, and I'll be starting my pain fellowship at Stanford in the summer.
And my name is Tessa, and I am a fourth-year neurosurgery resident at Albany Medical College, planning to do a functional neurosurgery fellowship.
Okay, so now we'll begin our section of moderated questions. We have about 7 questions that we'll go through, and then at the very end, we'll open up the floor to the audience for open Q&A. So the first question, what are some unique differences in pain presentation needs of underrepresented minority groups? And this question would be for Dr. Paul Su.
Thanks, Cece. So I think previous slide, I think, for the question, but with regards to kind of unique differences to pain presentation and needs as it relates to kind of sexual and gender minority population, I think the biggest important takeaway is that, you know, the patients still kind of present the same. They still suffer from the common pain symptoms that kind of plague the general population. But I think some things that I think need to be considered is the fact that this specific population, there's oftentimes other associated comorbidities that may play a significant role. And, you know, one example is the high prevalence of concurrent HIV and HCV infections in sexual and gender minority population. So, you know, that can predispose patients to neuropathies, for example, from the disease itself. You know, I think one that takes care of this population also needs to be knowledgeable and cognizant of kind of side effects of medications, which again can contribute to independent pain conditions, but also can interact with some of the treatments that you offer. I think the kind of examples that come to mind are you know, antivirals for these diseases sometimes can augment or inhibit metabolism of certain drugs. You know, as it stands right now, there's not really specific empiric recommendations to change how you would dose these medications, for example, opioids or other medications, but it is something to be aware of when, you know, antiviral medications are added or changed and, you know, your patient presents and their pain's different. I think another one that is specific, at least to the sexual and gender minority population, is the high incidence of kind of discrimination based on sexual and gender identities. And so these patients are, you know, at higher risk or exhibit more prevalence of depression, anxiety, suicidal ideations, and all of these put them at risk for developing chronic pain. And all of these are things that you kind of want to be aware of before planning neuromodulation trials, because that might actually affect your success and your outcomes. And, you know, maybe this places more emphasis on psychologic optimization before advanced neuromodulation therapies. So these are just some examples, I think, of unique needs of the group.
Thank you, Dr. Su. If any other panelists would like to add any additional comments, now's the time. And if not, well, then we'll move on to the next question.
Well, if not, then I guess I'll move on to question number 2. This is for Dr. Diaz-Ramirez. And the question here is, what are some examples you've seen of discrimination or bias in pain assessment or treatment of URM groups?
So I've been doing basically most of my career has been private practice. I've seen patients in the hospitals when they've come of different backgrounds. And what we see is that there has been a lot of barriers in terms of communication. That's a main issue. For example, in the English speaking population, then there's little time for us as physicians, maybe who don't speak or whatever language it is, to spend with that patient and explain all the things that have to do with an implant, for example, for spinal cord stimulation or whatever neuromodulation is. So that would be a very big barrier. not having that time to spend with that patient, being able to get a good translator available. And then what happens is that culturally, the patients might not trust the doctor because there hasn't been that connection. Many of them might not want an implant because that's not something that they will want in their bodies. So that's something to consider. Some people have told me things about religion, which have been different than what I've experienced through life. And that has been a barrier for them to get that, that service. In terms of if you put the comorbidities, for example, because of the way that many of these patients not have access to adequate medical care and to the time to be optimized in their other conditions, then you will see that they're not going to be good candidates. So it's like it's still it's like a snowball where you start with somebody who has a condition that of chronic pain, for example, in this case, and they develop like some diabetes on top of that. Diabetes is not well managed. It doesn't make them a good candidate. And then still the system will not accommodate for those challenges for that patient. So you have different components of that situation. I've seen that. I've seen patients who didn't have, they had basically, they were just medication because it was the easiest thing to do. And because they get to know that, then they might not be open to other alternatives. And it takes a long time to build trust, especially when you are of a different cultural background with the patients. You may not have the same way of communication, the same understanding of their family, of their social life. Those are basically barriers. So that's in general what I've seen with patients in the hospital, in the private practice sector as well. And in academics, my experience where it was more of a consulting. We would place these implants, and insurance was a big deal. It was a big limitation. So the patients might not have access to cover for that extra, like they don't have a secondary, if they're being covered through work, or they simply didn't have, a lot of times they didn't have access to health insurance that would cover these therapies.
And our next question, Sylvia, if we can actually advance one more slide.
Can I ask one question of Dr. Diaz Ramirez, if you don't mind? Just
oh, absolutely.
Sorry, I was on mute earlier. You mentioned in passing and didn't get any detail, but I just didn't really understand what you meant by it. So if you don't mind just giving me a little insight. You said there are some potential religious reasons or issues that might become relevant. Can you give me an example of that? I'd appreciate it.
So there have been patients, it's been a rare occasion where they told me that that's not permitted by their religion to have something external in them. It was rare, but it was something that I confronted in this population. I don't know at the time if that was just an excuse because they were scared and they were using, I cannot tell you if it was really a true religious limitation, but I've heard it from a particular patient who told me that their religion did not allow them to have things in them. So I don't know if that was an understanding of their religion or if it was just that the patient was not really wanting to have something implanted for them. So that was a limitation I saw with that particular patient. That really, it's been my experience that I saw that.
Thank you.
All right, and the next question we have sort of ties into this really well, and I think it's a really important idea to delve a little deeper into. So I'll direct this to a few more panelists. Dr. Olatoye, Dr. Su, and again, Dr. Diaz Ramirez. What are some barriers to effective pain management for these URM patients? And I know Dr. Diaz Ramirez, you addressed some of these, but just to kind of elaborate a little bit more.
I
You
mean,
want to start, Darren?
well, sure, I can get started. I mean, again,
Yeah.
I think some of the points you made are, very valid. And like you said, Tessa, it tied very strongly to the barriers here. I think for me, at least my take is pain is a subjective matter. And as such, it really depends on you just believing the patient. But now based on that, the implications of bias comes into play. And so I think one can look at the barriers in terms of how it's coming from the providers, the patients, and the system. So from a provider standpoint, provider bias has been shown to be very impactful in terms of the type of care patients will receive. And bias can be in form of implicit bias or explicit bias. I think explicit bias is a bit easier to understand and appreciate. Implicit bias is challenging, but frankly, I would say it's probably stronger than explicit bias. Numerous studies have shown that bias, both, again, projection to the patient and frankly, the perception of bias by the patient can lead to the patient not, number one, trusting the medical system, just like Dr. Ramirez mentioned. They might not want to necessarily go for advanced pain interventions because they might think that you are experimenting on them. They frankly will not even want to report their pain. Studies have shown, especially in sickle cell patients, for instance, they tend not to want to go to the hospital because they feel like they're being labeled, as drug seekers or drug users. So all of these things can certainly lead to poor outcomes. Provider bias can be seen in so many ways, condescending tone, lack of empathy, the assumptions, again, that patients are seeking, medications. Those things can certainly affect how patients view the medical system. Now, in addition to provider issues, there are also systemic issues as well. And again, some of these things Dr. Ramirez already mentioned. So some things like insurance types. Unfortunately, a lot of our patients who are underrepresented, they tend to have insurances that are considered federally funded. And as such, they might not be able to afford some of the interventions that we have to offer. I mean, to be fair, I think if you were to poll the audience right now and ask them how much out of pocket do you think a spinal cord stimulator cost, you might not be able to give that answer, but it is very expensive, right? And most patients, unfortunately, just cannot afford that. And so, I think we need to do a better job of perhaps from a financial standpoint, making some of these interventions more accessible. But even with that said, studies have shown that even patients with, underrepresented patients with, high socioeconomic statuses, they also still get discriminated against. So I think it still comes back to the whole idea and the implications of provider bias when treating those patients. And then lastly, one cannot underestimate, the history behind some of the lack of trust that minority patients have for the medical system. The Tuskegee experiment comes into play. Even the current issues with vaccinations right now. I have family members who don't even trust the medical system, who will never get vaccinated. And again, I think part of it is just, I don't want to be experimented on. I don't trust people. I don't trust the medical system. And I think it's up to us as providers to show that empathy and to show that some of these options are for their own good, so to speak. So those are some of the barriers that come into play, at least in my opinion.
One of these, the barriers that we haven't discussed, and I think we're going to discuss it in another question about the pipeline, is really access and knowledge, because what happens is that many of these patients will not have access to an interventional pain physician. Many of them will remain under the care of their primary care physicians who really don't have the knowledge, or it's, because of the education, the way our medical system is, they will not have the knowledge about these therapies. And so it might be that the physician has the best intentions with that patient. It might be that they're doing everything that they can within their reach, but it might be that they don't have the knowledge to be able to help those patients in their communities, and they don't have access to interventional. There's not many of us through the United States. And if you see, most of these implants are placed in the larger institutions and larger towns and cities. So many of these minorities will be in situations where they just don't have access because of lack of knowledge and access in general to physicians like us.
Yeah, and I couldn't agree more with everything that's been said so far, and to kind of build upon what's been said. I think in addition to kind of the inherent and systemic biases that's around both for the physicians, the healthcare system, I think there's also kind of overall a lack of education really for the providers to be taking care of kind of underrepresented population. So even with providers who kind of recognize their biases, there sometimes could be just an overall discomfort because they don't identify with these underrepresented communities. Like, what are some of the concerns that that the patients have? Maybe they're not trained to kind of to tackle those topics, and it kind of already kind of hinders and strains that trust and that rapport that you're trying to build with the patient. I think one example is how do you broach the topic of pronouns, for example, for transgendered patients, just being comfortable with being uncomfortable and being kind of showing humility and kind of a non-judgmental environment sometimes can be a barrier as well.
Thank you, panelists. If anyone else would like to make a comment, if not, we'll move on to the next slide, please, Sylvie. Okay, so this question would be for Dr. Olatoye. So what are some challenges that's unique to you as a URM physician in pain medicine, and how did you overcome them?
Yeah, thank you, Cece. That's a great question. I think certainly this is subjective and, it applies to me, but some of these things can also apply to everybody. I don't want to speak on behalf of every, URM physician, but, I do think some of this, challenges are also experienced, frankly, by non-minority physicians in their early careers, issues with, imposter syndrome or microaggressions, trying to find your niche, especially in an academic setting, or even frankly, just being viewed or accepted by your patients, right? Not just for what you look like, but for what you know. Those are things that, are, issues that I deal with, but as time has come along, I realize that some of it might be self-inflicted actually. When I'm talking to a patient, they simply want to know, are you just going to do a good job? Are you going to manage me well? Are you not, you're not going to screw up, right? And so I've come to appreciate that I need to separate, what I look like or what I perceive to be perhaps some discrimination to just being perhaps patients being anxious, all right? I often think to myself, if my mom were to sit in front of me and I was going to do an injection on her, she will probably question me several times and ask me, have you done this before? Right? That's my mom, right? And so I think ultimately appreciating that patients are coming in anxious and being calm, collected, answering any question, I think instills a lot of confidence in patients. But again, overall, I think I've been very, happy with my trajectory. Again, regardless of those things that I mentioned earlier, as far as feeling like an imposter, microaggressions from patients, I still, again, I'm very satisfied because you hear from patients about, thank you so much for, helping me out, or you see a handwritten note from a patient, or even you get a note from a trainee who just left the program, telling you that they really appreciate this teaching pearl that you provided to them, years ago. So those are examples of things that I think have, allowed me to overcome some of these, what I feel like a lot of times are relatively self-inflicted, or at least it's me, but realizing that there are still issues out there, but ultimately it's about doing the right job, doing it well, and making sure that the patients are treated adequately. That's really what it boils down to.
I just want to use this opportunity to kind of add on to what reiterate what Dr. Olatoye had mentioned. I think microaggression, or in some cases, just frank macroaggression, is definitely something that is very challenging as kind of an underrepresented physician. And, I think one of the kind of the pendulum swing, I think, in our society right now is to kind of recognize that a lot of this discrimination against underrepresented minorities has been systemic, and that I think one of the tools that I use both for myself and also to kind of establish an open and safe environment for my patients is to address microaggression. So, when I have patients that kind of, say certain things which, are kind of reinforcing biases, for example, I'll use either to myself or to anyone else that's in the healthcare setting, medical students, fellows, nursing staff. I'll use that as an opportunity to kind of educate them and to address that, so that, not only are you kind of helping yourself, but you're really kind of helping the overall kind of community as well by not perpetuating those microaggressions.
Well, the next question we have ties into this a little bit, and this is for you, Dr. Gorey. As you mentioned, actually at the last Diversity and Outreach Committee meeting, one of the goals or pillars of the organization is to increase diversity among pain providers. This focus obviously stems from a lack of diversity among pain providers. What are some of the causes of this, and what are some possible solutions?
Yeah, I think this is an outstanding question, and I would say there are a few potential causes. One is it's really hard to be something that you can't see. So talking for myself, I really did not know about chronic pain as a field until I was probably a third year anesthesia resident, to be perfectly honest with you. And I don't think that I had any interactions with a underrepresented minority pain physician until I was actually in my fellowship. Just the lack of minorities in underrepresented minorities in positions of authority, in podiums and positions to mentor, something that was definitely lacking when I was in the resident and fellow shoes. And I would say that that lack of those positions still continues, and it's something that I think that we need to continue to work on. I'd also say, and this feeds into the next question a little bit, that fit and feel are really dangerous, especially when it comes to small fellowship programs. And so I've been on the resident admissions committee for my university. I currently am the program director for a pain fellowship. And a lot of times when you sit down and you review applications, the rubric that often comes out in these conversations is who fits here. And who fits here often are the people who look like the people in the room. And if all the people in the room look the same, then the chances of you choosing someone who's different or someone who makes you uncomfortable is very slim. And so we have to be careful with the way that we choose residents and the way that we choose fellows. Because our natural, especially when you look at anesthesia residency, a lot of times when you ask anesthesia academics, what do they look for in a resident? They will say, someone that I want to stand in a room with for 2 or 3 hours in the middle of the night. Well, the person you want to stand in the room with is often someone who has the same interest as you. If you like to play golf, it'll be someone who likes to play golf. If you like to trade stocks, it's going to be someone you can talk about your portfolio with. And oftentimes that person will look exactly like you. And so I think we need to really examine, and I think the elimination of step one, while it does present some challenges to underrepresented minorities, I do think it gives us an opportunity to really examine how we choose residents and to make our application processes and our selection processes more holistic.
Well, that's a really great thought. And actually, I'm in the midst of being the interviewer and putting together a rank list for our residency program. And we really do emphasize the fit, but we don't necessarily think of the potential consequences that it could have from that standpoint. Does anyone else have any comments for this question?
No, but it does, as Dr. Gloria was mentioning, does feed into the next question. I think you actually answered it partially already, but I'll just go ahead and read it again so you can elaborate on it more since we have a little more time. How does underrepresentation in academic medicine leadership contribute to disparities, and what are some solutions?
Yeah, no, I mean, I think, I don't want to repeat myself, but I mean, that's it. I mean, the program directors are choosing the paying physicians of tomorrow, right? The deans of medical schools and deans of admissions are the gatekeepers to medical education. So as we make these decisions in academic medicine, and there are a lot of reasons that we have a lack of minorities in academic medicine, right? Some of it has to do with the large amount of debt that underrepresented minorities often have to carry. Sometimes they don't have the resources to stay in academic medicine. There's something called the minority tax, where often underrepresented minority or underrepresented physicians feel a need to spend time helping their communities, whether that be any community that they spend time in. And oftentimes that work, that diversity work, that work to improve equity in a field is not often represented in the promotion and tenure pathway. So one way we can change that is to make sure that that's accurately represented. And again, the lack of mentorship. While there are very few minorities or underrepresented minorities in pain medicine, there's even fewer in academic pain medicine. And so it's really hard to find mentors who can help you navigate some of the things that the physicians were talking about earlier, the microaggressions and the imposter syndrome, and figuring out your research focus and figuring out your niche and how to grow academically. And so when we don't have those people who are able to understand the importance of diversity of thought and often create departments and divisions that are monoliths, then you get non-diverse groups, and you also get groups that aren't effective at providing care for the communities that we serve. Because diverse groups mean diversity of ideas. It also means a better understanding of the community around you, and that means better patient care in the long run.
Great.
I think, Lawrence, can I add something?
No, go ahead.
Yeah. I was going to say, I think I think there needs to be an investment as well from the leadership to not only select these people, that to promote, their retention in academic medicine, but also to kind of foster and kind of invest in them in terms of kind of the tutelage and guidance. So I think it's, I think it has to come both ways. There needs to be kind of that outreach and mentorship and kind of encouragement to kind of have people interested in the first place, but from a system standpoint, also to have the resources to make sure that they succeed. Because there's nothing worse than, having, almost just like collecting, for the sake of having that diversity checked off, but then only to have them not be supported and essentially fail. And I think that just kind of shoots the institutions in the foot.
So Dr. Gore, how many people are on your fellowship selection committee, and how long do they stay on that committee, and how often do they rotate?
Yeah, it's a good question. So our committee is rather small because our fellowship's rather small. We have 5 people on our fellowship selection committee. We don't have a lot of rotation because we don't have a lot of physicians. We have 5 physicians in our group. But I think one of the things that we do is, one, we have a very diverse group. And that is something that's important to us as a university. It's important to me as a leader. And I think we have an inclusive group, or I try to create an inclusive group in that conversation where everyone's voice is respected. But I think around these conversations of diversity in selection of residents and fellows, we need to really create a culture of safety where people feel comfortable speaking truth when they feel like decisions are being made that aren't under the lens of inclusivity. And I think that is really the most important point in an academic process, is if you're in a room and it looks like the residency director is choosing someone because they feel like they're their buddy and they just had a good interview with them because they talked about, I'll pick on myself. I love football. I also love mixology. And so if someone sits and talks to me for 30 minutes about football and mixology, we're going to have a good conversation. I'm going to leave being like, I like that person. And so I want my colleagues who have different interests than me to be able to say, you only like that person because they like the stuff you like. You don't like them because they're actually going to be a good resident or fellow. And I think that's the most important piece.
Jonathan, can I ask you something? Because I've been in private practice since I graduated. I do teach for the university, but they basically come to my private practice. I never really go to the university, and it's medical students. So when I was in my residency, it was an elective to go through and rotate through pain management. And you would rotate and do maybe 2 weeks out of your whole residency. In my personal case, I went to pain because I ended up with an injury that did not allow me to work in the OR for an extended period of time. So they dumped me in the pain center, and everybody headed the pain center. But I had the opportunity to see the patients come and see the change in their lives that the pain physicians were doing. And then it allowed me to in surgery. So my question is there room, I don't know that there is, to have longer rotations and longer opportunities so that the residents really see what the change we can make, or the changes that we make, the transformations that we make for these patients? Because I had that opportunity only because of a personal injury, and pain took me to pain. But that's not something that really we have much knowledge. Like you said, you didn't know what pain management was until you were in your residency. And I didn't have the experience, the thorough experience. I only had it because of my injury. But not many people really understand what that means to be an interventional pain physician, even during residency, which I think is a limitation of our training.
Yeah, I agree 100%. And I beat this drum all the time at my institution that, I'm an anesthesiologist, and pain is a subspecialty. Treating chronic pain, anesthesiologists do a lot of things, and one of those things is treat pain. My specialization in treating chronic pain does not take away from the fact that I'm an anesthesiologist. It's a subspecialty of the specialty, in the same way that a GI doctor is a subspecialist of internal medicine. And so because of that, I've advocated for our residents to spend at least 2 months in chronic pain, especially in light of the opioid epidemic, where I think having a good understanding of how acute pain transitions into chronic pain is extremely important, kind of in holistic care of our patients. And also, I would say for the anesthesiologist, as I don't know how many of us will be sitting stool in an operating room 20 years from now with the increase in technology and the safer that we're making. Anesthesiology is way safer even now than when I was in residency. I think we have to learn how to be perioperative physicians, and chronic pain is going to be a part of that. So I say all that to say that at our institution, all of our residents have 1 month during their CA2 year, and they can have anywhere from 1 to 3 months during their CA3 year. I'd be interested to hear how we have other academicians on the call. I'd be interested to hear kind of their thoughts. But I also think it'd be great, academics is very different from private practice. And as we build these programs, I think it's also important to make sure that our trainees are exposed to the world outside of the academic center.
Yeah, so to your point, yeah, so I agree with you, Dr. Gore. Yeah, so I think exposure and the frequency of it, I think, makes a huge difference. Here at Mayo Rochester, our residents actually have a very robust exposure to chronic pain. They can do as many as 3 months. They certainly spend time as first just doing inpatient pain, so more acute and chronic. But yeah, and that has, I think, helped us in terms of recruitment. But even beyond what residents see, I think, at least for me, my personal belief is start young in terms of how you capture these interest, right? And so even going as far back as medical school, medical students, right? You have SNMA, you have other organizations that are catered towards underrepresented, medical students or minorities. And so these are areas that I think are open, so to speak, for outreach. And so if we can somehow make these connections much early on, that only plants the seed that generates and blooms into an interest down the road. Oh, I remember as a medical student, this person was telling me that there's more to pain than just opioid management. There's actually interventions that I can offer my patients. Maybe when I'm a resident, I'll think about that. And so that could definitely foster interest in the field much earlier on, as opposed to when things are a bit too late and the chances of applying into the field has more or less diminished. So I think we need to also look into, what we can do to capture or at least reach out to some of these, students much earlier in the careers.
Yeah, at UCSF, we have, the 1 or 4 week rotation as a CA2 that's mandatory for all our residents. And, occasionally in their CA3 year, they will come back for a day here or there. But in the medical school, I think the UCSF School of Medicine, I think did a really nice job by offering pain medicine or chronic pain medicine as a 4th year elective to their students. And UCSF Medical School is also really unique in the sense that the anesthesia rotation is a required rotation as part of their major clinical year. So for some schools that's not necessarily the case. So I think the School of Medicine did a really good job in terms of exposing what is kind of sometimes a less highlighted specialty compared to medicine and surgery and things like that. I was going to mention something else that I forgot. I'll just end there.
All right, well, I think we've have this last question here, and Dr. Gorey is going to have to sign off, but I think it's very relevant to one of the questions we have from one of the attendees. So maybe we should just take that question because they're sort of related and just pose it to the whole group. Anna is asking, how can current medical students become more prepared to advocate for URM and anesthesia residency? And that's an interesting question. Maybe start at the top of the list here and see what others have to think about that.
I think appropriate training, I think, is really important. I think knowledge is power. Here at UCSF, for example, the institution has gone great lengths in terms of providing diversity, equity, and inclusivity training to all its faculty and also medical students, kind of education on implicit biases, microaggressions, and then kind of to intervene on them. So coaching skills on how to identify and intervene to really create inclusive environments. So, techniques not just for, it's easy for attending physicians to point out and kind of address microaggression, but as a trainee, I can imagine, I personally have had experiences when I was in training where, how do you approach a situation where you're, on a hierarchy level, it may be kind of uncomfortable, or sometimes you might be scared to kind of tackle these inequities that you observe.
I'll weigh in on that as well and say that maybe exploring once I don't know if you're planning on doing your residency in the same place as your medical school training, but nonetheless, identifying faculty members you can talk to and relate to and maybe bring up these issues be important to do early on. And that way you have some support and understanding from those who have been in whatever system you're in, and to have a sounding board to discuss it with. I think that's always an important key point, and that allows you to then bring these things more to the forefront when you experience them, and bring up your interest more to the forefront and bring it forward for your colleagues to discuss and act on.
Yeah, I certainly echo everything that's been mentioned. I think also being involved in national organizations that allows you to interact with people that are, beyond your sphere, so to speak, right? And you get to interact with like-minded people, people that maybe share other interests, or frankly, even other ways that you may have not thought about. One could think about advocacy on a political level. I know medical students that get involved with creation of laws, which ultimately impact our patients. So there are so many avenues, but being involved in a national organization such as this, or frankly, several others, allows you to interact and get some of these ideas, and you can just take it from there. So yeah, I think that's another opportunity as well.
Absolutely.
I was actually, I just remembered another point too. I think, going back to the last question about kind of retention in academic medicine, I think, being able to identify inequities in underrepresented populations, that could actually just, be a launching pad to an academic career itself. Creating research questions that, investigate the inequities, and to implement policies or, research projects that target that. I think one example that came to mind is the fact that one of the principal investigators here at UCSF, who does a lot of work with pulse ox, kind of just started realizing that, hey, people that are non-Caucasians, the pulse ox readings are not accurate. So so that kind of spun off into a major research project that's, highlighted in anesthesiology. So, you can really identify these inequities in underrepresented populations and really kind of use that to your advantage, and, be a champion.
Well, I think, should we go to our next slide? I believe that this was our last formal question. I mean, we kind of opened it up a little bit. If any of our attendees have any questions, now's the chance to add those to the chat, and we can address those. And as we wait for those to come in, we'll just kind of open it up to the panelists if you guys have any other specific questions or things that you wanted to talk about.
Well, I just want to add that through the pipeline that Dr. Guri is going to be working this year, and that has started before, for the Diversity and Outreach Committee, we have items put in place, actions put in place, things that are being planned, so that we can start reaching out to the medical students, the general population, and then going down step by step in different areas. And we'd like to invite whoever's in this call and hasn't had the opportunity to join or reach out to the Diversity and Outreach Committee. If you want to participate as part of these events that are going to be happening, these efforts that are going to be part of the NANS Diversity and Outreach Committee, you're more than welcome to come and join us, so that you can also help in narrowing that that discrepancy that we have, that disparity that we have with minorities having access. So Jonathan, I don't know if you want to tell a little bit of what we have going on, but I think that would be a good point for them to understand that they're invited to contribute and be part of this movement to decrease the disparities for minorities.
Yeah, no, I appreciate that segue. One of the goals that we have this year is to really develop pipelines to underrepresented organizations in medicine. We've begun some of that work. NANS is going to have a session at the NMA national meeting this year. Next month, we are hosting a journal club for SNMA to talk about disparities in neuromodulation. And I know that Dr. Poirier was in a group on this call that really that wrote an article that really outlined disparities in neuromodulation. We are also looking to develop those same pipelines with Latino medical student organizations, LGBT medical student organizations, South Asian medical student organizations, primarily women medical student organizations, engineering organizations. And so anyone that has relationships with any organizations, a former member of any organization, I'd love for you to reach out to me. Our goal is to really solidify these relationships this year so that we can, because what I've found out or what I've learned is that when medical students and early residents learn about neuromodulation, it's something that's really cool. And they often want to jump into a neuromodulation related field, whether that be neurosurgery, neurology, anesthesia, or PM&R. If any of you want to join us in those efforts, my email is jhgoree, JHGOREE @uams.edu, jhgoree@uams.edu. Feel free to email me. We had our first meeting to kind of push forward this effort Tuesday, so 2 days ago. So you are not behind, and we'd love to have you. I'll also add in the chat, someone asked a question about financial scholarships for URM residents and medical students. And this year, NANS gave 5 awards, which were basically financial support to come to the national meeting. 1 for a resident, 1 for a fellow, 1 for a medical student, 1 for an engineer, and 1 for a researcher. And so we are currently seeking funding to continue that program as the Diversity and Outreach Committee, because we do also agree that it's important, and oftentimes underrepresented minorities don't have the funds, especially early in their career, to get to meetings and network and make it to the podium 10 or 15 years from now. And so thanks for bringing that up. It's something that I hope continues, and I hope it's a trend that NANS starts that other organizations will soon follow.
Well, we haven't heard from everybody on the panel. Maybe one of those who hasn't spoken up would like to make some comments. Sylvie?
And we do have another question in the chat about advice specifically for women wanting to pursue a career in neuromodulation. So I can at least start to add that there are a number of helpful organizations and mentorships associated with that, including the Women in Neuromodulation component of NANS, in which one of the things that we are trying to focus on is engagement with medical students and residents, and sort of working to create a conduit into neuromodulation. So that is a good resource to explore from that standpoint.
And I'll just add that the WIN committee is onto the board, and that got formed maybe 4 or 5 years ago, is now the largest committee and probably the most active committee at NANS. And so it's grown by leaps and bounds, and has been terribly fantastic and impressive in this growth. So you can't beat joining that if you want to get involved in neuromodulation.
Yeah, there's actually quite great mentors there, from neurosurgeons to interventional pain physicians that come through anesthesiology or, different specialties, PMR. And we don't only belong to this community and to the to NANS. There's other institutions as well, there are associations, and we are all very active. And there's a lot of mentorship that happens. Even in social media, you can find some groups that are available, very active as well. And the things have changed really since, I have to tell you, I've been doing this for over 21 years, and all the time I would only be the woman in the room, but things have dramatically changed, and there's a lot of opportunity, and you can offer services. Many times people come looking for a woman or a man, or a different gender, somebody closer to them. And it's been amazing, the development that has happened. So you have tons of opportunities to connect with women like you.
I'll jump in on this next one. Questions: are there any opportunities to help NANS create any educational material in different languages? That has certainly come up on both the NANS board and the INS board, and there are certainly people doing some of that. I've had some of my pain fellows who primary language is Spanish translate some of our NANS documents, and we get assistance from Spanish speakers from around the world, because nuances could be different depending on where and how you speak your Spanish. But there's still lots and lots of room to grow on that, and both the national and the international societies are working on some of those things through their educational committees and their outreach committees. So there's a lot of work to be done. There's a UCSF, we claim that there are 150 languages spoken by our patients. And even with that, we have translators for those 150. And even with that, I find that there are times when I don't have a translator for the language of the patient I'm seeing is speaking. So there's lots of room for growth, and reaching out to the educational committees and the outreach committees could really help. There's endless amounts of work that needs to get done. Remember, everyone that's a member is a volunteer. So we welcome volunteers to help us out in all aspects. So don't hesitate to jump in and lend a helping hand.
I think we answered all the questions in the chat. One just popped up. So what are your thoughts on having spots reserved or allotted for URM and medical schools, residencies, and fellowships programs to make sure they're given a spot on the table? This would enforce medical systems to adopt and adapt them by accepting members out of their comfort zone.
I prefer to change the paradigm of how we choose students, instead of kind of having a system where we guarantee spots. I think we should make access more equitable and understand kind of what makes a holistic applicant, and really use this time to have that conversation about what diversity brings to the table, and make sure that access to all these programs is equitable kind of across the spectrum.
Yeah, I agree with that as well. I think it has less to do with the quota versus actually making sure that the applicant is qualified in several ways to be at this program. And frankly, sometimes the criteria we use for interviews, I think could also be modified. What gets the candidate into the door, right? I think sometimes we're checking off a list of our step scores and some of these more nuanced measures that perhaps don't often reflect how good a candidate is. We need to modify those things. And then once the candidate is at the interview, then they have the time and opportunity to shine. And I don't necessarily think a quota is needed for that. But yes, certainly some of the criteria that we utilize for our interviews, I think could be modified. That would open more opportunities for underrepresented minorities.
Well, great. Well, thank you, everyone. I think we have reached our allotted time. If we can go to the next slide, we just want to thank everyone for attending our webinar, to all the panelists for joining us and being a part of this important discussion. To our attendees, as we mentioned over and over, we are very eager, to work with you, whether through the Diversity and Outreach Committee, through the Women in Neuromodulation. Please reach out, and if you're on Twitter, follow us on Twitter for more information, more events, and we look forward to working with you.
Good night. Thanks for the invitation.
Thank you, everyone.
Have a great night.